I think there are different ways of conducting goals of care conversation. I think the first step is really to get to know the patient, either through the patient him or herself, or through the family if the patients cannot really provide you that information. I think it's important to learn a lot about how their life has been, having a background, understanding how was their functional status within the last months or even years, depending on what the situation is. Um, what do they enjoy in life or they used to enjoy in life? Trying to understand their perspectives into healthcare, on healthcare delivery, on invasive workup or invasive interventions, um, what is their spirituality, what were what are or maybe social barriers, and then move on into really having a conversation regarding disease trajectory. So from my perspective, I think I really try to understand who the patient is as a person, not from the illness perspective only, but again socially, spiritually, and then trying to conduct the conversation and and trying to explain in very lay terms what is the clinical situation for patients, what is the prognosis, what it has been the course of the illness, what has been the trajectory both functionally, nutritionally, for the patients, and then dive into the different components that we discussed during goals of care conversation, which again has to do with, what are what is the ideal situation for patients, and hopefully they can actually verbalize by themselves what do they value in their lives, what are their beliefs, and then move into the type of medical interventions they really want, especially in the context of all the conversation that has been had. What level of treatment they would like to have. Do they align with certain interventions like intubation, resuscitation, um, artificial nutrition and hydration? And again, that includes parenteral nutrition or feeding tubes within their context of their prognosis and their illness. And the other component that is very important is really to guide patients on giving us the information, try to document it in an official form as best as possible. And we have different documents and tools to document these conversations, but also figuring out if at some point of time patients cannot make decisions, who would be the best person to advocate for their wishes. Sometimes it's not the closest person in the family or the highest in the ranking from family members that they feel that are going to advocate for their wishes. So it's important to have that conversation and document whom the patient would prefer to really be their advocates and their voice when they cannot talk to us and give us their perspectives.
So goals of care conversations really pertain to having a discussion on how patients view their illness and their condition and their hopes and their preferences as far as their uh, treatment plans, and also their other aspirations for the future, and really having the patient think through on what they want for themselves, what they see that their care should be, and also though putting it in the perspective of where they are at as far as their health condition. Um, Goals of care can really mean many things to patients. It could be as simple as wanting to go home. Simple if that is, of course, readily available. Of course, we do have patients who wish to go home but may not be feasible. But that's often going home for patients who are, of course, in hospitals are often verbalized as a specific goal of care. I've had patients who would say, I want to be here when my first grandchild is delivered, and or I want to walk my daughter down the aisle. So goals of care, as I've said, really is specific to the patient and specific to their own personal views.
Well, I think they're the culmination of an individual's values and beliefs and preferences for how they're cared for and how they're treated as they approach the end of their life. And I think it's important to really explore those, recognizing that sometimes they change over time. So it's not a one-off, it's a process. It's sort of figuring out what is at the core of a person and what's important to them is really what goals of care means to me.
I think the general rules of life apply to the general rules of healthcare, which are, if you do it right to the best of your ability the first time, which is going to take time, you're going to save yourself a lot of challenge in the long run. And so an example is, commonly people will want palliative care to have a goals of care discussion. Can you please get the do not resuscitate? And you've just met these patients and their families, never before. And it just doesn't work like that. You have to build trust. You don't go in there talking about, hey, how do you feel about cardiac arrest being death and CPR won't work and you'll probably remain deceased? You can't lead with that. You have to take time to build the relationship, and that's not always going to happen, if ever, in a first encounter. Maybe not the second, maybe not the third. It might be the fourth, could be the fifth or the 10th. But again, if you're willing, and we are willing as palliative care providers to put in the legwork overall upstream, it's going to help the healthcare system long term, because you're going to be, in theory, and by statistics and by data, reducing acute care visits, reduce ER observations for symptom crises, because you've taken the time upstream to work on the why and the goals of care. Planning is really synonymous with palliative care, is that, again, you're talking about what's happening, number one, at a period of time when you're having the conversation, but how does that period of time, what's going on medically, how does that compare to what was happening previously, whether that was a month ago, 6 months ago, a year ago? And moreover, what do we anticipate medically that this is going to look like in a month, in 6 months down the line? And have you thought about what that would mean to you, and what would you hope for yourself?
There's a time and a place for the one and done. If we have an acute situation, then that's a different situation. A person is highly functional, living alone, has an acute stroke that has left some serious residual deficiencies that we need to address. That's a different situation than someone who has had a long-term chronic illness that the patient is deteriorating and may be reaching a point where they are unable to care for themselves, or their caregiver is starting to realize they may not be able to meet their care needs. Try to find their comfort zone in where they are in having these conversations, and to try to enter into that conversation with an open mind. I think one of the best pieces of advice, or what I learned the best, and I actually have it taped onto the top of my computer because I look at it every day, is to follow the principle that I learned from the Buddhist monks that work in palliative care. And it's not knowing, bearing witness, and compassionate action. So to go into an encounter with kind of a blank slate, don't really go in with any preconceived notions about what this conversation has to yield. And then to bear witness, to listen and to learn who that patient and family, what's going on within that encounter. And then to move forward with compassion and caring. And if you do those three things, you really can't go wrong with wherever the conversation ends.
This might be wildly unsatisfying, but it's the same way that, I've had to do it, is that you just have to do it. It's like a muscle. And do I get it wrong sometimes? Absolutely, because you have different audiences and you're going to have to adjust for that. Figure it out as you go along, and there's no other way to get better than to just fumble through. Maybe people can watch trainings, like I do this for a living, and even for me to try to convey to someone, like, how do you do it? You do it by, someone giving you with the basic tools. I can give you a script, but the delivery of it, there's an art to it, and that art can be interpreted.
I basically looked online for available scripts, and I would start using a script. And when you do try and use a script in order to open up conversation or whatever issue you're discussing with the patient and the family, I also would recommend really looking at the body language, the reaction of the patient or the family member to what you're saying. I've had scripts that I had to discard because I found them confusing for patients and families, or that they generate a negative response from the patient or the family. Like I've been in situation before where the patient starts cringing, like physically you could see their face get all twisted up by what you've said. So I know never to use the same thing. I've also had a response that was difficult for me to then answer back. A good example, a lot of the scripts you'll find, they'll say that after you deliver a bad news to the patient or the family, you can follow it up with a question that says, what do you fear most? When I tried using that, what do you fear most? The common answer I get from the patient was, of course, to die. You've just told me that I have cancer. And I was really at a loss on then how to respond to that. And I've avoided saying, what do you fear most? And I've changed it now to just saying, so what do you worry most about? And that to me actually provides me with a better opportunity to dig deep into what concerns the patient, after having at least knowing that they have a life-limiting illness.
I think when you explain to families what to expect during the dying process, they feel a lot more comfortable, with making decisions and being at the bedside, and coping with death. Having social support and having spiritual support is also important at that particular juncture. And again, these are not easy conversations. But definitely, these are much easier conversations if you have met these families before and you've had some level of conversation before.
I think it's always important to remember who we have to be true to, and that's always the patient. So we're there for the patient, but part of that person is their family, however they define their family. So I always want to start off by asking how involved the patient wants their loved ones to be, because for some there may be limited involvement, and that just may not be consistent with an individual's preferences. And so if I were faced with a family that were really struggling with even broaching that discussion, I think I would share with them that it was something that was important to their loved one, the patient, and that really by engaging in that discussion, they're really helping them and providing them with a gift to be able to openly and candidly discuss goals of care. So I would try that approach, really try and highlight for them that it's an important thing for the person that they love.
The primary challenge is that you have to be able to feel the temperature of your audience, number one. Number two, you have to make people, again, I think this is really important, let them understand that they have the space to engage with you on the same level. Because oftentimes in healthcare, there's this unspoken mismatch of authority, which makes things hard in terms of trying to bond with someone. You have to respect people's intelligence, right? Because humans are really, they're intuitive, and they know if you're talking to them like they're an idiot. And I don't say that to be funny or to go off the cuff, but that's true. Like, you really have to, in many ways, meet people human to human, because you have to gain trust with that patient and their family, right? You're about to talk about some major issues that are affecting them either, in real time, or have been affecting them on a continuum over the long haul, and have some tough conversations. The first thing you have to do is really meet them where they are, to take time, look them in the eye, allow them the space. That's about 90% of it, that people need to feel like you're listening, that you acknowledge them.
I think one of my starting questions for patients is to ask them what matters to them, what's important to them. And I like to sort of just use that as a starting point and kind of guide the conversation where the patient wants it to go. Often I've come across patients that say, I don't really want to talk to you. And then we have a very long and involved and very open conversation. So I try and take my cues from the patient, but I just start off with very open questions. What's important? What are you worried about? What matters to you? Quality of life is such a unique thing. It doesn't really matter. It's not really important how I define quality of life, but what is important is to define how our patients and their loved ones define quality of life, because it could be very different, and we can't impose what we think is the standard or what is a good quality of life on somebody else. So it's just really important to kind of remember it's a unique and very individual perspective.